My personal gratitude and thanks to Professor Umair Chaudhary for giving me this honor, and he's always been very kind. जी. Okay, so I'm Dr. Asim Javed. I'm an interventional cardiologist at Rawalpindi Institute of Cardiology, and my task today is to talk about possible role of cardiologists in establishing these mechanical thrombectomy services in developing countries like Pakistan. So I'd like to go a little fast so that I leave some time behind for questions. So I would say that stroke interventions parallel primary PCI for STEMI. So what's common in both? There are blocked arteries with thrombus there, and you have to remove the thrombus. The only difference being that the cardiologists have to remove the thrombus in beating heart with moving arteries. In the brain, you've got static arteries. So unfortunately, majority of the world does not have mechanical thrombectomy services. So if we look at the figures, out of a total of 2,000 centers, 78% of these are based in US, UK, Brazil, France, Germany, and Australia. Rest of the world, you barely find these services. Last night I was trying to dig out some data. So I looked at UK 2020 data. So this is 89,000 strokes in that 1 year. 77,000 were ischemic strokes. 35 to 40% expected to be LVOs. 10 to 12% expected to be candidates for mechanical thrombectomy. Only 1.5% actually received mechanical thrombectomy. So these figures are UK statistics official that more than 7,000 eligible patients each year were unable to get mechanical thrombectomy services. So why is that so? So again, I tried to dig out a little more. So only 3 hospitals in UK at that time were providing 24/7 stroke thrombectomy services. Whereas at the same time, 62 hospitals were providing 24/7 primary PCI services. Again, number of INRs working in UK at that time were 81, and 7 were scheduled to complete training in 2020. Another 8 were to complete it in 2021. So by end of 2021, there would still be 96. At the same time in 2020, 713 consultant interventional cardiologists were registered with UK, and they were already working on a 24/7 rota. So this is the latest publication that came from Iris Grunwald. I think majority of you probably would be knowing she's a neuroradiologist working in UK doing mechanical thrombectomies. And this is a question that was asked: can interventional cardiologists help deliver the UK mechanical thrombectomy interventional program? So this is a recent survey by British Cardiac Interventional Society, which shows that 52% of interventional cardiologists, when asked, they agreed to contribute to stroke mechanical thrombectomy service as part of the 24/7 service after appropriate training. So I tried to look at a few more countries. So this was interesting for me. St. Petersburg, only 25 patients per year were being treated with mechanical thrombectomy, and in 2015, they started an interventional stroke program involving interventional cardiologists and their cath lab network. And as a result, with combining skills of INRs and ICs, the program treats 650 cases per year with mechanical thrombectomy, and their reported successful reperfusion rate is 81%. Again, if you look at different European countries, you can see a huge variation there, and a lot of European countries still need to come up with these services. Same 2020 comparison of United States, 834,000 strokes, 726,000 were ischemic, 275,000 were LVOs, and how many underwent mechanical thrombectomy? 9,000. That's only 3% patients were able to get mechanical thrombectomy. So neurointerventionists at that time in US were 1,200, and at the same time, look at the human resource that was there in the form of interventional cardiologists and radiologists, that's 8,000. Now, this is EuroPCR 2018. So I'm going to show you the original slides of that presentation. This is a key message from the inter-society meeting of European Stroke Organization, ESMENT, and many more. This is their original slide where they showed that countries where interventional cardiologists already are participating in mechanical thrombectomy services, that's Cape Town, South Africa, Czech Republic, Turkey, USA, Netherlands, Slovakia, Denmark, Portugal. The important thing that they also mention here is that training of new interventional neuroradiologists would take more than 2 to 3 years, versus training of experienced interventional cardiologists, that would be as short as less than 2 to 3 months. Again, this is their slide, because not every cardiologist they would recommend to do this. So they would recommend any cardiologist who's completed training in interventional cardiology with at least 3 years experience afterwards, and then they have to gain experience with DSA procedures, with carotid angiographies, carotid stenting, and then they have to do 25 assisted thrombectomies and then 25 thrombectomies as first operators before they become independent stroke interventionists. This is the same thing, and in this diagram they also are recommending to do ESMENT course, which is the ESMENT stroke diploma. So I'm proud to say that our cardiologists are now doing this. A lot of them from NICVD, from RIC, we have already done these stroke diplomas, so they are quite useful. This is a study which was done in Prague, where they compared interventional mechanical thrombectomies done by cardiologists versus other vascular neurologists and radiologists, and there was no statistical difference between the outcomes. So this is our Bible of interventional cardiology, textbook of interventional cardiology, Topol. And now carotid and stroke interventions are part of the curriculum of interventional cardiology. It's in our curriculum now. So I tried to find some statistics to reflect what's happening in Pakistan. So if I first compare United States, this is publication by Professor Ansar Tariq Rai. He's a close friend of mine as well. So STEMI 70 to 80 per 100,000 per year in USA, and ischemic large vessel occlusions is 31 per 100,000 per year. So I tried to extrapolate the same onto Pakistani population. So that means we should have STEMI of at least 160,000 to 180,000 per year, and ischemic large vessel occlusion should be more than 70,000 to 90,000 per year. This is, I'm extrapolating the US figures. But if I look at the Stroke Association publication from Neurology Pakistan, according to them, this LVO burden is more than 100,000 per year. So if you look at different cities with their populations, Karachi should have more than 5,000 LVOs per year. Our Rawalpindi, Islamabad has over 1,000 LVOs per year. So we have a huge burden to deal with. The number of interventional neurologists that we have, I think we can count them on fingertips if I'm not wrong. So at Rawalpindi Institute of Cardiology, we are a public sector institute. So we took this initiative. We are a 272-bed tertiary care cardiac center. The center started in 2012, so it's not a very old center. We have 24/7 CT angio services. We've got 2 CT scans in our ER. One is a 128 slice Canon CT, the other one is a 640 slice Aquilion 1. And we've also got the Canon stroke artificial intelligence with that. We have a 3 Tesla MRI, so we are well positioned with the imaging. So our hospital is financed by Government of Punjab. We have 4 cath labs at present. One is a biplane, one is a hybrid lab. The best part is that all emergencies are treated free of charge. So even if we have to give TPA, even if we do mechanical thrombectomies, we do primary PCIs, no matter what we do, the patient pays nothing. The operators don't get anything, and the patient pays for nothing. And everybody is entitled there. So at Rawalpindi Institute of Cardiology, we started off with training. My first exposure was with simulators and 3D flow model and animal lab experience in Malaysia. That's the first time when I realized that this is something doable. Then I went on to comprehensive stroke centers in USA, so Ansar Tariq Rai, West Virginia, and Adnan Siddiqui in Gates Vascular Institute. I'm very grateful to them for their all-out support. Then we acquired TPA, we acquired mechanical thrombectomy devices, We have our stroke neurologist, who's our hero. So if you don't mind, Salman, can you raise your hand? So our whole stroke program is indebted to Dr. Salman. He's our stroke neurologist. He's leading the program. So we have 7 to 8 consultant radiologists supporting us. We've made our hyperacute stroke unit. We have a stroke clinic. We have a rehab department. And we have neurosurgical backup. We've signed an MOU with our neighboring hospital where the whole department is. And we've got BBH, and Dr. Lubna is sitting here. They are supporting us with all the patients whom we do not intervene. We refer them to their department for admission and further care. So this is what we've been doing. I spent stroke diploma. Then I got certified by WIST. So we have a WhatsApp group on which we have everybody there, and we run the whole stroke code over there. All the consent forms, everything is linked up here. This is clinical audit. So we have every day, first thing in the morning, we have the last 24-hour audit that is presented for primary PCI, mortality, and stroke. All these 3 audits are presented. So this is actual slide of one of our audits that was done in December 2021. So you can see here, stroke codes conducted 20. So now on average, we do more than 25 stroke codes per day. That's the volume we've gained. So we keep a check on all the timings. You can see door to groin puncture time, one was 88, the other was 105. Door to needle time was 52 in these cases. Then we have breakdown of all the patients presented so that we can find out why the delay was there and how we can address that delay. And then we have these, all the LVO finding patients where we've intervened or not intervened. Everything comes up with their aspect and all so that we can review. Just quick 3 slides about our data. So we started, the first intervention was done on 13th April 2018. We started 24/7 service on 5th April 2021. We've done more than 9,000 stroke codes so far. 75% of RIC stroke codes, the door to CT time of less than 20 minutes was met. No money charged from any patient for imaging or anything. That's our yearly distribution. You can see it's an upward trend. Continuously, the flow is going up. So far, we've done 378 mechanical thrombectomies. We were very slow to start. We were careful, and at the same time, we had limited it till 2 o'clock in the afternoon, but then by 21, we realized that it's not going to pick up unless we make a 24/7 service. So I was doing it all alone for these 4 years, so I decided to go 24/7, 2021. But then I started training people with me, and slowly, gradually, we'll be building up, and then the volume is now going up. We've had few months in 2022 where there were a lot of supply chain issues, and we were short of supplies. So far, we've given 194 TPAs. TPA alone was 127, and 67 cases it was TPA with mechanical thrombectomy. Again, there've been supply issues, but now Martindo is there. So now we've recently taken 200 from them. So hopefully there will be no more issues. So we've been trying to run workshops and courses to train other interventionists from all specialties. Whatever limited knowledge we have or skills we have, we are happy to pass them on. This is the first big workshop that we did where 200 interventionists attended. These are 2 courses that I run, which are more theoretical and audiovisual based and case based for 20-25 people at one time. These are more of awareness courses, and then I'm also running 3-day hands-on stroke workshops because now we get anything between 1 to 3 stroke and mechanical thrombectomies per day. So if somebody comes to me even for 2 days, they get an exposure of anything between 3 to 5 mechanical thrombectomies during those 2 days. That we are doing in collaboration with Medtronic as a clinical proctor for them. This is just glimpses. So now Cardiac Institute's performing 24/7 stroke intervention service in Pakistan. It's Rawalpindi Institute of Cardiology here and NICVD in Karachi. Institutes where cardiologists have performed a few stroke interventions are Taba Heart Institute, Hayatabad Medical Complex in Peshawar, Peshawar Institute of Cardiology, and Gumpert Institute of Medical Sciences. These are not neurology services at present. These are cardiac patients who on the table had stroke, but having attended these workshops, they were able to rescue their own patients on the table. So my message would be that teamwork is the key to success. No specialty alone can handle the huge need for stroke intervention. Interventional cardiology has the required skills with availability of cath labs and CT scans all over the country. With support of neurology and radiology, interventional cardiology can play a vital role by performing mechanical thrombectomies. May Allah give us the strength and wisdom to reduce the misery of stroke disability, and may Allah protect us all from ever becoming dependent on others. And before I finish, I just want to show you a 2-minute video clip of Professor Nick Hopkins, who's a pioneer neurointerventionist in USA. And this is what he has to say about the role of cardiologists. Can I have the volume, please?
I'm an interventional cardiologist from Cape Town, South Africa. And with me is a very honored guest, Professor Nick Hopkins from Buffalo, New York, who's a neurosurgeon and pretty much pioneering the field of stroke intervention. The need, because that's the issue, is getting cardiologists involved. What training do they need? And there's a lot of legislation issues, I think, but there is a pushback by the neurointerventionists to not have cardiologists involved. But in the short term, millions of people are suffering. And what do you think about the training programs?
Very interesting topic, because if you look at the neurointerventional community guidelines, they look like a simple turf barrier. But in reality, the way they were designed originally was for first-time users, because the person who goes through a neuroradiology residency, he hasn't done much of any catheter intervention when he gets to his INR fellowship. So the fellowship guidelines are really designed for starting from scratch. And what I think they ignore is the fact that interventional cardiologists are very skilled at catheter interventions. As a matter of fact, if you think about what do cardiologists do all day, they open up occluded arteries, exactly what we need for stroke. But they do it on an awake patient in a moving target, because everything's moving in the heart.
With bifurcations and lots of calcium. To end, Nick, where do you think this field is going? Just to summarize and...
Yes, great question. I think, if you look at the fact that there are 16 million strokes in the world, and if you look at the number of neurointerventionalists that are available to treat them, it doesn't even treat a small fraction of the strokes. So we've got to have help from our cardiology colleagues to handle the public health issue of how do we treat these patients. If we can return a patient from aphasic and hemiplegic and completely out of it, nursing home candidate, if we can return that patient to an essentially normal life, it's a huge benefit to the public health. So we have to figure out a way to satisfy the public health, ignoring turf, and working on ways to get cardiologists enough training to understand the basic needs for...
Thank you very much.
Thank you very much for the patient and especially helping neurology colleagues. Now I have a couple of questions. One, what is the maximum timing limit for you to perform this mechanical thrombectomy? And number two, do you make it routine to give TPA before mechanical thrombectomy?
Thank you very much, sir. Both are great questions. So I'll answer the second question first. TPA, we've always had the supply chain issues. We've never had regular supplies. Now with Martin Doe giving us 200 TPAs, we hope that we'll be able to give TPA to everybody who deserves TPA. Otherwise, in between, there were days, there were months when we did not have TPA. So we had to rely on mechanical thrombectomy alone for LVO patients. But if a patient qualifies for TPA and mechanical thrombectomy both, we will give them both. If he qualifies for TPA alone, we will give him TPA alone. As long as we have the resources. So at present, we have them. As far as the time duration is concerned, we try to stick to guidelines, but then we have to look at our own resources as well. So initially, we were limiting ourselves to 6-hour time window. Now, with the artificial intelligence coming in and with all the perfusion maps and all, although the recommendation now I think the international faculty here will bear me out that the guidelines are now that with the perfusion maps, they are there to include more patients rather than exclude patients. But at present, if it's a large core, we have to exclude that large core. Otherwise, time window, we are happy to go up to 24 hours. We do perfusion scans for them. We have MRIs. So we look at all the flare mismatch and all, and then we decide for the patients. It's all individual based.
Dr. Amir has
Please.